I'm Ali Smith.
And I'm Nick Kendrew.
We're both part of the Red Whale team.
Come with us to reignite your passion for primary care.
Welcome to the Digging Out the Halloween Costumes episode of the Primary Care Pod from Red Whale.
The Primary Care Pod from Red Whale.
So grab your preferred drink of choice, which might be a pumpkin spice latte, or your trainers, clutch your pearls, and let's start with the headlines. Here's what's coming up. Idiopathic nephrotic syndrome is the most common paediatric glomerular disease. Despite this, we won't see it very often, but a quick reminder might help us spot it.
Named after an octopus trap and sometimes called broken heart syndrome, Takotsubo cardiomyopathy is being diagnosed more frequently. In fact, 2% of people initially labelled as having acute coronary syndrome will end up with the diagnosis.
Halloween is less than 2 weeks away now. How do I know that? It's not by checking on my calendar. It's because my appraisal is also on Halloween. And so I've just had the deadline to submit everything. So deep breaths, fingers crossed that's going to be okay. Anyway, let's start with our third pearl of the month and nephrotic syndrome in children. Now, this one took me 10 minutes, 24 seconds to read. So a medium-sized pearl, a decent latte, I would say. So what did this one mean for you, Ali?
Did you know there were a couple of anxieties that cropped up for me when I was reading this? One is because of when I was in paediatrics, there was a consultant who always told me to be careful when I was a GP of seeing a child with periorbital edema and not misdiagnosing it as allergy, because he said that's something that happens a bit in primary care. So remembering when you see puffy eyes to dip a urine, and it's one of those things that always stays in the back of my mind, and I have this sense that I might miss something. But that's a useful tip. And then the other anxiety is around the shared follow-up role that we sometimes have with secondary care, and just in terms of being happy that families know what they're doing with things like daily urine dips, and that we know what we're supposed to do with those results. So I find this a little bit anxiety provoking, but I think the article's very helpful with that.
Yeah, and it's funny that you say that about the consultant saying that to you about the puffy eyes thing, because when I kind of read this, it was a few years ago, and I remember thinking I must safety net properly about this so that a parent doesn't miss puffy eyes in their child, and that it might need to be seen by us. And I think I'd seen somebody who had just straightforward conjunctivitis, and I just completely tied myself in knots, and it completely messed up the safety netting. So it's really important to do it right, isn't it? Because otherwise you create anxiety that shouldn't be there. So it's getting that balance.
Absolutely.
Right, isn't it? Yeah. I think I was giving my anxiety to the parents. So only happened once, and it hasn't happened since, but it's important to be aware of. So idiopathic nephrotic syndrome is the most common paediatric glomerular disease, and it's characterized by heavy proteinuria, also low plasma albumin leading to edema and increased risk of infection. Treatment is usually with oral steroids, and prognosis depends on how well the condition responds to treatment. Most children will respond well to steroids, and as a result, mortality from nephrotic syndrome has significantly reduced. However, long-term impacts are common due to the frequent high doses of oral steroids required. In primary care, we need to be aware of how the condition might present, but also of the long-term care these children need to help prevent relapses and reduce the risk of serious complications. This article is largely based on a 2023 Lancet review, unless we otherwise say. Now, as always, full references are in the written pearl. So, Ali, let's go back to the beginning. What is nephrotic syndrome?
Well, if you're anything like me, the intricacies of renal pathophysiology might not be your strong point. So I thought it might help to keep it quite basic and think about how we would explain nephrotic syndrome to patients and families. So I've paraphrased the following information from a resource from the patient information group, the National Kidney Foundation, and from the NHS Conditions information page on nephrotic syndrome in children. So, nephrotic syndrome is a collection of symptoms that may occur when the filtering units of the kidney are damaged, for example, by infection. And this damage allows protein, normally kept in the plasma, to leak into the urine in large quantities. And this reduces the amount of protein in your blood, which in turn means that fluid can leak out of the blood vessels into the tissues, which causes swelling. And this loss of proteins can include antibody proteins and proteins involved in blood clotting, meaning children are at greater risk of catching infections and of developing blood clots. So the likely underlying cause of nephrotic syndrome in children differs depending on the age at first presentation and the degree of responsiveness to initial steroid treatments. So most children will have minimal change disease, meaning that the kidneys appear normal on biopsy. And this is also known as idiopathic nephrotic syndrome. Although this is the most common glomerular presentation in children, it remains rare, affecting around 3 in 100,000 children per year. Genetic factors are responsible for up to 30% of cases of steroid-resistant nephrotic syndrome, and most of the cases presenting before 3 months of age, so those are the congenital forms. Other causes can include cytomegalovirus, parvovirus, diabetes, sickle cell disease, HIV, hepatitis B, and systemic lupus erythematosus. There's a useful table in the Pearl which goes through some important definitions, so let's run through those. So congenital nephrotic syndrome, as I mentioned, would usually be suspected in children aged 3 months or younger. Idiopathic nephrotic syndrome, which is steroid sensitive, is the most common type in children, although it's still rare, and the definition here applies if children achieve complete remission within 4 weeks of starting steroid treatment. Steroid-resistant idiopathic nephrotic syndrome is the label that we apply when children do not achieve remission after 4 weeks of steroid treatment. And we'll tell you a little bit more about the definitions of remission and relapse in a moment. So Nick, how might nephrotic syndrome look in primary care?
Let's consider how things might be at first presentation. So nephrotic syndrome typically affects children aged 1 to 10 years. However, it can occur in younger or older patients in an atypical presentation. So for many children, there will have been a triggering event in the weeks before onset, such as an infection or allergic reaction. So if we look at the symptoms and signs, then edema would be there, and it's commonly periorbital or affecting the face, the hands and feet. And in severe cases, there may be ascites or pleural effusion. We'd also be looking for signs of hypovolemia and also things like increased weight. Signs of infection would be apparent too in some cases, so fever or lymphadenopathy or chest or urinary symptoms or peritonitis in some cases. There might be abdominal discomfort. There could be fatigue or dizziness. There could be frothy urine. That's one that we might all think about. Also thrombosis. So consider thrombosis in children with chest pain, headache or neurological signs. Also hematuria or severe abdominal pain. And hypertension, elevated blood pressure is rare and it might indicate more severe disease. All children presenting for the first time with suspected nephrotic syndrome should be discussed with our paediatric colleagues because they will need urgent blood tests. So let's look now at testing in hospital. Investigations on admission may include a urine protein creatinine ratio, also urinalysis and investigation for hematuria, bloods including full blood count, renal function, albumin, also wider immune testing such as complement, ANA, anti-streptococcal antibodies and anti-neutrophil cytoplasmic antibodies, assessment for any dysmorphic features, ambiguous genitalia or family history of kidney disease, also examination for any rash or arthritis. Kidney ultrasound and biopsy is not routine, but will be considered in atypical presentations or where the nephrotic syndrome does not respond to first-line steroid treatment, and genetic screening for congenital nephrotic syndrome or steroid-resistant nephrotic syndrome. So can you tell us a bit about the treatment, Ali?
Well, Nick, during the acute episode, secondary care treatment is usually with oral prednisolone. And the paediatricians will usually give high-dose oral steroids daily for 4 to 6 weeks, followed by a slightly lower dose on alternate days for another 4 to 6 weeks. and prophylactic anticoagulation and management of fluid status and any concurrent infections may also be needed. But all of that will be looked after in secondary care. Home monitoring then usually involves urine dipstick daily until remission. And remission is defined as a negative or trace urine dipstick for protein for 3 or more consecutive days. Then after that, there's urine dipstick twice weekly, long term. And then if the child becomes unwell or if a dip returns a protein level of 1+ or more, then they return to daily urine dipstick testing. And then thinking about relapse management, a relapse is defined as at least 3+ of protein on urine dipstick for 3 consecutive days with or without edema. It's common for children with nephrotic syndrome to have relapses until they reach their teens, and it's important that relapses are identified and treated early to reduce the risk of complications such as acute kidney injury, hypovolemia and thrombosis, which can occur in 1 to 4% of episodes. And just to reiterate, children need daily urine dipstick testing during subsequent illnesses due to increased risk of relapse during that time. And when it comes to treatment of relapse, there's no specific guidance in the UK as to when a child might need admission to hospital to treat their relapse. We would suggest you discuss each case with your local paediatricians because children who are well might be managed at home under the guidance of their secondary care team. You'd normally resume prednisolone treatment at the dose advised by secondary care, tapering that dose to stop according to the response. And during a relapse, blood pressure and weight should be monitored twice weekly. For children with persistent or recurrent relapses, steroid-sparing drugs such as mycophenolate mofetil, cyclophosphamide or rituximab may be considered in secondary care.
Now, preventative care is important too, so let's think about vaccinations. Live vaccines such as nasal flu, MMR or MMRV and BCG should not be given while on immune suppressing therapy. Immunisation may need to be completed prior to starting immune suppressants or be delayed until a gap in treatment. Due to the increased infection risk, comprehensive vaccination is important for these children. And the advice we're going to give is UK advice, and it's taken from NHS guidance, and that's the NHS Nephrotic Syndrome in Children, and also from the Green Book as well. And the Scottish guidance, we'll also put a link in the show notes to that as well. So that's all going to be there. So pneumococcal vaccine, the Green Book advises that antibody levels decline rapidly in individuals with chronic renal disease. So re-immunisation is therefore advised every 5 years, and that's according to the Green Book. Influenza vaccination is advised annually. If immune compromised, then don't give the live nasal flu immunisation and instead give the injection. And varicella vaccine, it may be advised in some children, but again, this is a live vaccine, so be careful about that. Steroid safety is important as well. Children on prolonged or repeated courses of oral steroids are at risk of steroid complications. This is now the greatest cause of morbidity in children with nephrotic syndrome. Our article on safe prescribing of steroids, which is on Redwell Knowledge, has detailed advice on the checks that we need to consider for safe monitoring in adults, but in children, secondary care may advise quarterly blood pressure, height, weight and BMI, yearly height velocity, and consider vitamin D testing in patients who receive oral steroids for at least 6 months. The frequency of ophthalmological assessment and DEXA scan will be established on an individual basis for that patient. So here are your learning points for nephrotic syndrome in children. Idiopathic nephrotic syndrome is the most common paediatric glomerular disease. It presents with heavy proteinuria, low plasma albumin, edema, and increased risk of infection.
Treatment is usually with oral steroids. Prognosis depends on how well the condition responds to treatment. Most children respond well to steroids.
Long-term impacts are commonly due to frequent high-dose oral steroids. In primary care, we need to be aware of how the condition might present, but also of the long-term care these children need to help prevent relapses and reduce the risk of serious complications. Okay, so it's time now for a group hug. As usual, this part of the podcast. and the part of the podcast where we celebrate getting through a difficult day in primary care with our best intention story. So thank you to all of you that have emailed in, and also to those of you that have been texting in your stories recently. However, we do need your ongoing help to put a smile on everybody's face. So whilst you listen to the story this month and have a think about what your best intention story would be, and then please send it in, and our contact details are in the show notes. So here we go. And this one says, "Hello there. My name is Karen and I'm a GP partner in a semi-rural practice near Bath. I was delighted to chuckle along with your listener who had experienced the embarrassment of being presented with a urine sample in a champagne bottle. And this story reminded me of a similar incident that once happened to me. In the days when GPs routinely saw pregnant women for their antenatal care, I was happy to see a young couple during their first pregnancy for a routine check. They dutifully came in, handed me the file of pregnancy care notes, and placed what I assumed was a urine sample in a random plastic bottle on the desk. Whilst chatting to them to put them at their ease, I picked up the bottle and used a dipstick to test the contents. I was rather alarmed to see the instant and definite colour change associated with significant glycosuria. Employing my very best Breaking Bad news spiel, I carefully explained the process for further investigation and what this might mean for Mum and the remaining pregnancy, to which they listened very meekly before pointing out that I tested her energy drink and the urine sample was still in her handbag. Needless to say, I was mortified and have never made the same mistake since. So, my learning points are to continue to chat to my patients to put them at their ease, to make sure my poker face at work is one of the best in the business, and always check what something is before you open the bottle to test it. I was lucky. You might not be." And they also say, so thank you, Karen, for that. Karen also says, "Thank you for all your brilliant podcasts, which make my CPD accessible and a joy." So thank you, Karen, for that.
Love that one. Check what's in the bottle. What good advice.
Wise words. Thank you. Yes. So have you got the calendar there, Ali?
I have, Nick, and this is a really exciting time of year at Red Whale. We're about to launch another season of the GP Update course. So that will be available as live hosted courses online, which I think you're presenting one of the first ones of those, aren't you? Pretty soon.
So if you're going to be around on the Saturday, the 19th of October, then I'll be there with Kate Grint. We're going to be doing the Red Whale together. So maybe see you there.
Yeah, so that will be brilliant. There'll be the live hosted courses, including next one. There'll be the on-demand online course. There's going to be good old-fashioned face-to-face courses running in London and Manchester as well, with the new GP Update content. And what else have we got coming up? There's a live hosted urgent care course coming in November. There's face-to-face women's health courses coming. And just as this season of the update course launches, the whole cycle begins again. So I've got a pile of journal articles and new guidelines that I'll be sifting through along with the other authors, and we'll be writing some more articles and starting to think about what we'll teach in the spring-summer 2025 season. And another really exciting opportunity that I want to mention is that for GP trainees, you can sign up for absolutely free Red Whale knowledge access. That's our huge bank of over 900 online articles. If you are an MDU affiliate in England, or if you're a member in Scotland, Ireland and Wales, and that will be absolutely free. There should be a link in the show notes for how to sign up for that. And another really exciting thing for trainees and trainers is that our colleague Io has done a fantastic webinar on workplace-based assessments with Kim Emerson, who is the RCGP lead on workplace-based assessments. And that is free to access for absolutely everybody on redwhale.co.uk. So loads in the calendar this month, Nick. I think that's everything.
Yeah, that jam-packed calendars. Thanks for that, Ali. So let's move on to our fourth and final pearl of the month now, and Takotsubo cardiomyopathy. Now, this one took me 4 minutes and 14 seconds to read, so a quick espresso shot of learning to finish with. So what did this one mean for you, Ali?
Takotsubo cardiomyopathy is also known as broken heart syndrome, isn't it? And when I was reading this pearl, I found myself thinking, wow, this condition is one of the most straightforward examples of the mind-body connection in medicine. The idea that patients can have a huge objective physiological change to a major organ as a result of emotional distress. I just find that really fascinating.
Absolutely. And Takotsubo cardiomyopathy is named actually after an octopus trap, would you believe? So as Ali said, it's also called broken heart syndrome and is also sometimes referred to as apical ballooning syndrome or stress cardiomyopathy. Now, the written pearl is based on a review in the Journal of American Academy of Physician Assistants from 2020. So, Ali, why do we need to know about this?
Well, Nick, it's actually being diagnosed more commonly. About 2% of those with an initial acute coronary syndrome diagnosis actually end up with a diagnosis of Takotsubo cardiomyopathy. And what we see in this condition is acute stress, which can be emotional or physical, resulting in ventricular dilation and left ventricular dysfunction. So the clinical picture initially is that of acute myocardial infarction. However, no coronary artery obstruction is present. And 90% of cases are in postmenopausal women, and 95% of people with the condition make a full recovery.
As I said earlier, it's a fascinating condition, and I found it so desperately sad to read about people that actually died from a broken heart. So what's the physiology behind it, Ali?
So the exact physiology behind it is not understood, but emotional or physical stress causes the left ventricle to dilate, usually at the apex, resulting in reduced ejection fraction and acute heart failure. And this apical dilatation gives the heart the appearance of octopus traps used in Japan, which is where the name Takotsubo comes from. And it's thought that the adrenergic system drives these changes, although exactly how or why this causes apical ballooning is not clear. However, adrenergic changes are unlikely to be the only cause because, one, many people experience severe stress without developing Takotsubo, and two, Takotsubo doesn't occur in those who have pheochromocytoma, where catecholamine levels are often very high. So some wonder if there might be an element of vascular dysfunction, because it has been noted that both migraine and Raynaud's, which both involve vascular dysfunction, are also more common in women. So how might a patient present, Nick?
Well, presentation would actually be similar to acute myocardial infarction. So symptoms would be chest pain, dyspnea, dizziness, generalised weakness, sometimes syncope, and signs would be tachycardia, often lung crackles, and hypotension. Systolic ejection murmur may be heard because ventricle ballooning may cause mitral regurgitation. Peripheral edema is rare. Now, let's be frank, we're going to be sending anybody who's got those symptoms into hospital. Now, in hospital, investigations would also suggest an acute MI, so there would be ECG changes with ST elevation and T-wave inversion. Biomarkers, troponin or NT-proBNP would show a rise, but, this is the important bit, coronary angiogram reveals no blockage. In about a quarter, a trigger, such as stress, is not identified. Now, diagnosis is by the specialist using the Mayo criteria, and in brief, transient dyskinesis of the left ventricle without evidence of obstructive coronary disease. Treatment is supportive until the left ventricular function returns to normal, and in most, this is usually within 21 days. Some require intensive input, whilst others have much milder symptoms needing minimal support. Serial echoes are done to monitor recovery, and pulmonary edema is treated with vasodilators such as GTN and diuretics. ACE inhibitors or ARBs and beta blockers are often used to reduce cardiac load and control hypertension if it's present. And mineralocorticoid receptor antagonists such as spironolactone may be used for cardioprotection. If there are large areas of ventricular hypokinesis, then anticoagulation is used.
Yes, and as we said, the prognosis is pretty good for most people with this condition, with 95% of people returning to normal cardiac function within a few weeks. Hospital mortality is around 5%, mainly from hemodynamic instability. Men are at more risk of death than women, as are those with atrial fibrillation, although this is thought to be due to hemodynamic instability and reduced ejection fraction rather than thromboembolic events. And in 7% of people with Takotsubo, a major cardiovascular event, so stroke or MI, occurs in the first 30 days after diagnosis. The risk of recurrence is about 1.5% per year, with a cumulative incidence of about 5% in the first 6 years. And ACE inhibitors or angiotensin receptor blockers may reduce the risk of recurrence, although there is mixed data from trials. Beta blockers probably don't reduce the risk of recurrence. So what does this all mean in practice, Nick?
The bottom line is that we will never diagnose this in primary care. If a patient is discharged from hospital with Takotsubo cardiomyopathy, then remember that their coronary arteries are normal by definition. So aspirin, clopidogrel, statins, all of those are not required. Some may be on ACE inhibitors or beta blockers, and the hospital should advise how long these should be continued for. And also, because by definition their coronary arteries are normal, then don't forget to exclude them from CHD for cough. So, here are your take-home messages for Takotsubo cardiomyopathy. It's a secondary care diagnosis.
This is not coronary disease, so aspirin, clopidogrel and statins are not indicated.
Now, before we go, we've had a voicemail, so thanks, Anthony, for this. Let's have a listen.
Hi, Caroline and Nick. Just really enjoyed your podcast on HRT regimes. A couple of points, just to clarify that we're talking about micronized progesterone as being body identical, not bioidentical. I know it sounds similar, but they mean different things. And certainly I found it quite confusing when I had a patient tell me about this the first time. And secondly, just the role of the newer combined oral contraceptive pills, so Qulera and Zoely, because they have natural estrogens, and certainly in women of reproductive age in their 40s with perimenopausal symptoms, these are completely reasonable alternatives, and actually will give suitable endometrial protection, control perimenopausal symptoms, as well as providing contraception. Just my little sort of feedback, but it was a great podcast as per usual. Thanks very much.
Some really interesting points there, Anthony. So thank you for that. And luckily, we're quite well connected here on the podcast. So I was able to forward your voicemail to Lucy Cox, who is our lead for the Women's Health course. And here is her response.
Hi, this is Lucy from the Women's Health team, and thanks to Anthony for taking the time to comment on the Red Whale podcast and to make some really good points regarding the terminology surrounding bioidentical hormones. So, body and bioidentical hormones tend to be terms which are used interchangeably. So, bioidentical HRT has become synonymous with compounded hormones which are manufactured in the private sector and which are not products supported by evidence nor regulated and often marketed as natural hormones, therefore bioidentical. So the term body identical HRT was introduced to differentiate these products with conventional HRT. So that is estradiol and micronized progesterone, which we can prescribe on the NHS and which are identical to endogenous female hormones and therefore also bioidentical, but we term them body identical. So moving on to the combined pills Qulera and Zoely, and as Anthony points out, these also contain body identical estrogen and are both contraception as well as oral HRT. So 2-in-1 products, which are great potentially for perimenopausal women. However, they are not used very commonly in the NHS, mainly because they are more expensive than other combined pills on the market, and there's actually no evidence that they are any better than the cheaper combined pills. So for anyone out there wanting to know more about contraception and menopause, or maybe women's health more generally, please do consider joining us on our either online or face-to-face women's health courses that we are running in the autumn. So I hope to see you there. Bye.
Thank you, Lucy, for that. And also thanks again to Anthony for your voicemail. And if you've got a burning question, then all you have to do is send us a voice message just like Anthony did. And if you go to the show notes and you click on the bit where it says send us a voice message, then it will come through to us and we will do our best to answer it for you. Now, if you're hankering after a Red Whale Knowledge subscription, then we're offering a 10% discount on Red Whale Knowledge for our fabulous Red Whale Pod members. And how do I become a member, I hear you ask? Well, if you're listening to us, then you are part of the pod. So welcome. And all you have to do is go to redwhale.co.uk, put Red Whale Knowledge in your basket and enter your code, which is Red Whale Pod, to get 10% off. Here's the small print. The discount is only for this product and it won't work on anything else, no matter how hard you try. I know what it's like with those vouchers. You Google them, you try them for a discount. It's not going to work for anything but this. And please also note that this voucher code is all one word and it's all lowercase, so it's Red Whale Pod.
If you've enjoyed listening, then please give us a 5-star rating on whichever platform you use. It only takes a few seconds and we'd really appreciate it. If you can spare a little more time, then please leave us a nice review. Because of the way the algorithms work, it means that other people just like you can discover us.
Of course, putting algorithms aside, there is no greater recommendation than a word of mouth recommendation. So if you've got some value from listening to the podcast today, then don't keep it a secret. Please tell everybody that you know who might also benefit from listening. All the resources that you need are in the show notes and all the links are in the show description on your preferred podcast platform.
You can also find us on social media. We're on Facebook, Instagram, LinkedIn and X. If you want us to see something about the podcast, then please use the hashtag RedWhalePod.
And the other thing that you can do, if you click on the link in the show notes, then you can leave us a voice message telling us about anything that you found helpful or would like us to go over.
Yes, and you can also email us. Our email address is podcast@red-whale.co.uk. Until next time, I'm Ali Smith.
And I'm Nick Kendrew.
Remember to keep Red Whale Knowledge open on your desktop at work so we're with you when you need that extra bit of information or reassurance.
Take care and look after yourself. Bye-bye.
Goodbye.